All right, so again, we don't have just a whole lot to do today. Did you get my email by chance?
Yes, sir.
Yeah, okay. So we don't have, again, just a whole lot to do today, so we shouldn't be here all that long. Just a few projections, and we could spend 2 semesters dissecting this book. It's got a lot of specialty views in it that we could talk about, but the views that you're going to learn, if you go to work in an orthopedist's office or something like that. So just for general hospital work and normal clinic work, you're just not going to see those views, so we're not going to cover them. So there are a few things we need to talk about those. So we looked at that one. The Grashey Method is fairly common even in hospitals, and some places call it a true AP, and it's not really a true AP, it's AP oblique. And the degree of obliquity varies according to the patient's the shape of their body. So if you've got a patient that's kind of kyphotic, then you may have to use a different obliquity than somebody who's not kyphotic at all. So probably a steeper obliquity if the patient really has a straight back than if a patient's kind of kyphotic. So it's 35 to 45 degree oblique towards the side of interest, and the purpose for the Grashey Method is to try to open the glenohumeral joint space. So it's always going to be the side down, and really the only thing that you're looking for is the area around the humeral head. So we oblique the patient just enough that we can see the open joint space between the glenoid cavity and the head of the humerus. So it's 35 to 45 degree towards the side of interest, and you collimate down just to the area directly around the humeral head. That being said, some hospitals will use the Grashey Method as their AP. So if the Grashey Method is being used as the AP, then you need to follow the hospital protocol and include everything that you would include on a normal AP. So most of the clavicle, realistically, if you open up to midline, because of the degree of obliquity, you're going to get the entire clavicle on there. Most of the scapula, and to include external rotation and all that. So, but the Grashey Method by itself, without any of those special circumstances, is just to show the glenohumeral joint space. So the evaluation of the Grashey is, let me bring up the image. First off, let's look at this. Can you see this little thing right here? Sticking out, that little shadow right where my finger's over it, my finger's gone. You see that little shadow that changes as I oblique this thing? Mm-hmm. Okay, that's a corcoid process. And your evaluation of the Grashey Method and whether or not you've got good rotation is going to depend on 2 things. And now I'm going to bring up the image. The Grashey Method, okay, so here's corcoid process here. All right, so the main thing that you're going to look at is the glenohumeral joint space, so whether or not it is open. So it's mostly open here. It's probably not a perfect Grashey Method, but it's pretty close, right? You can see daylight, so to speak, through that glenohumeral joint space. So it's open. It's not perfect, but it's open. Now, the corcoid process is going to be projected sort of into the joint space and a little bit on the humeral head. So the 2 things that you're going to look for is, first off, is the glenohumeral joint space open? If it is, you're done, right? It's a good Grashey Method if the glenohumeral joint space is open. If it's not, then you're going to look at the corcoid process, and we're going to look back at this guy. So if we were shooting straight AP, where is the corcoid process? Right there, yeah, stick it straight out the front, right? So as we oblique the patient up, the corcoid process is being projected more laterally, right? Until, like on this image, it is actually in the joint space and over a portion of the humeral head. So as we oblique up further, we're going to get more superimposition of the corcoid process. Now, even on our shadow here, we've got superimposition over the humeral head. So the more lateral you become, over-rotated you become, the more superimposition you're going to get between the corcoid and the humeral head. Does that make sense? So the first thing you look for is the joint space open? Yes, the joint space is open, you're done. right? It's good. Know the joint space is not open. Now look at your coracoid process. Is your coracoid process more lateral into the humeral head, or is it more medial and away from the humeral head? If it's away from the humeral head, then you are under-rotated. If it's more into the humeral head, you are over-rotated, right? So just those two things. Really a pretty simple view. Not a whole lot to it. So we've got under rotation here. We've got barely any superimposition, if any superimposition between the coracoid and the humeral head. Our glenoid cavity, glenohumeral joint space is completely closed. You can't see any separation between the scapula and the humeral head. So we're completely closed. That's the first thing we'll look at, and then we look at the coracoid process. It's projected more medially. We're under-rotated. And then we've got over-rotation, really closed glenohumeral joint space, and the coracoid process is well into the humeral head. That's what over-rotation would look like. All right, so the Y view we talked about when we were talking about the proximal end of the humerus. So we're not going to go through all the details of that. A couple of things that we need to touch on, though, is, again, your body positions will be 45 to 60 degree oblique. And so the times that you're going to shoot a Y view would be for one of two reasons. One is for proximal humerus fracture, right? Well, three, let's say. Another is dislocation. We're talking about dislocation, what that's going to look like. If the patient has dislocated shoulder, most of the time it's going to be anterior. It's anterior, inferior, and on the Y view, it puts the humeral head into the ribs, into the lung margins. If it's posterior, it's just going to be out in the middle of nowhere, right? So that's your dislocation. You could do it for fracture, you could do it of the humerus, or you could do it for fracture of the scapula itself. The positioning is identical. The only difference between a positioning for humerus fracture / dislocation, shoulder dislocation, and scapular fracture is position in the humerus. If you're shooting for a scapular fracture, you got to get the humerus out of the way. Scapula is thin bone. You put a thick bone like the humerus on top of it, you could interfere with diagnosis. So you want to get the humerus out of the way. So the position of the humerus really is the only difference between those. So if you've got a patient with suspected shoulder dislocation, broken proximal humerus, then you're just going to leave the humerus where it is, right? So that you can see the humerus superimposed on the scapula. But if you got a broken scapula, just get the arm out of the way so that you can see the scapula just as much as you can. Keep in mind that there's a lot of positional pain with shoulder injuries, and if the patient has a potentially broken scapula, it's going to hurt a lot, but look how little you actually have to move the humerus in order to see it. It's not a whole lot, right? So get it out of the way, whichever way is easier for the patient because of the construction of this thing. It doesn't want to go posteriorly, but it can go in either direction. It doesn't really matter. Just get it off of the body of the scapula. So they're the same. But you can evaluate also your degree of obliquity and whether or not you're oblique enough versus not enough by looking at the two different borders. So your the vertebral border, the medial border of the scapula is very thin and it's fine, right? It's just a pencil fine line in appearance on the image. But the axillary border is kind of fat and puffy. So what you're going to look at is where is the fat and puffy part versus where is the thin part. So if you've got superimposition over your ribs, then you're rotated in one direction or the other. Question is, what part are you looking at over the ribs? If it's the fat part, over the ribs, then you are to lateral, right? So the fat part is here, and as we oblique up more towards lateral, then it superimposes on the ribs, the thin parts back here, right? Conversely, if you're 2PA, then the vertebral border, the thin part, is going to be over the ribs, right? So that's the only thing that you're going to look for as far as obliquity goes to make sure that, you're, 2PA versus 2 lateral. So are those two borders on top of each other? Do you see a good Y? That's the first thing you're looking at. And if so, then you got a good Y view. Is it for humerus fracture? If it's for humerus fracture, just leave it alone. Right? You can see a humerus fracture through the scapula. You might not be able to see a scapular fracture through the humerus. So if they suspect the patient has scapular fracture, get the humerus out of the way, providing the patient doesn't have a broken humerus too, right? And then you're in a pickle, I'd still just shoot it with the arm hanging. You can't really get it out of the way. Okay? So we talked about, the positioning, put your fingers on the vertebral and the axillary border and oblique until they're superimposed, and good luck with that. So that's my positioning there. It's a subtle obliquity from your hand being perpendicular. And it's been, almost 2 weeks. So put your hand on the scapula, put your hand vertical, and then oblique, if you're shooting PA, oblique back down about 5, no more than 10 degrees, and you should have your scapula pretty much perpendicular. Looks like that. Should look like that. Should look like that. Okay, so again, it's not perfect, but it's pretty good. You got your vertebral border, you got your axillary border, so they're not perfectly superimposed, but I would not repeat that. And it made it into a textbook. So AP versus PA is your choice. Most people shoot them AP. I always like to shoot mine PA. I point some of these things out because if you're the outlier in the hospital, you really kind of need to mark your images as such. If everybody else in the hospital is doing their Y views AP and you do yours PA, it might look like you mismarked your images compared to theirs. So you might want to make some sort of annotation on the image that you shot at, PA versus AP, just to make sure that there's not any kind of confusion. Okay, so we talked about dislocations and all that. So we have under rotation. I mean, that's we're getting close to an AP there. So I can't tell if that's under rotated Y view or if that is a rotated AP. But we've got the vertebral border, which is the axillary border, which is your lateral border. Notice how puffy it looks as opposed to the vertebral border. Is just a nice thin line. And we've got over rotation, and it looks like we've even got a little bit of quantum model going on here. So probably what happened is a lot of the photocell was probably exposed to direct radiation, direct exposure, and it shut off the exposure really quickly. All right, so AP clavicle, we've got a couple of things to talk about on AP clavicle. One is because you're shooting at a very small bone and you're collimating, you should be collimating pretty tightly to that bone, and your central ray should be to the bone itself, and your photocell may be sticking up above the shoulder, it probably will be, and it's going to receive direct radiation, right? Even if you collimate down, it's going to receive direct exposure, and it's going to have a tendency to shut off your exposure too early. Your index number is going to come out looking like you underexposed the patient. So probably a good idea to compensate for that with either setting a technique, right? If you happen to have a good technique. If you don't, and you don't want to just wild guess it, then what you can do is just go ahead and hit it, collimate as closely as you can, and go ahead and hit it with a +2. Remembering that a +2 is going to cause your photocells to receive more radiation before sending the signal to the timer to discontinue exposure. It'll compensate for a little bit of that direct exposure to the photocell, right? So Central right to the mid-clavicle, 10 by 12 crosswise, yeah, but you're going to collimate down, so it's really going to be more like an 6 by 12. So you can shoot these PA. I've never done it before, but you can shoot them PA. And it's something that Merrill's points out, and it's in almost every registry review book that you see as a potential question. How would you increase sharpness of recorded detail if you're shooting clavicle? And that would be, you can back up 72 inches if you want to, but that's another thing that I've never done a clavicle at 72 inches. So the answer choice is usually PA, right? So to reduce OID, you would shoot PA. So that, just a nugget that you need to put away. Reduce OID, increase sharpness of recorded detail. So if the patient's kyphotic, you're going to have a hard time with your clavicle for two different reasons. One is that if you got a kyphotic patient, they're going to have a hard time laying flat on their back. They have a tendency to want to roll to one side or the other. So really recommend that you shoot them upright. But at the same time, with your kyphotic patients, what's going to happen is that their clavicle, just like on a chest x-ray, their clavicle is going to be projected lower into the lung field. Right? So it's not going to look like an AP clavicle. It's going to look like a AP axial clavicle with the angulation going in the wrong direction. So if you have a patient who's kyphotic, if at all possible, do them upright. It's more comfortable for them, and also you're going to get a better result as well. So we talked about the we talked about the AC joints before we broke. But what we're going to look at is, for rotation, we're going to look at the sternoclavicular joints. And what you should see on your AP of the clavicle is superimposition between the medial end of the clavicle and the first two ribs. And realistically, on your AP axial, it's not going to be a whole lot better. Even though you have a cephalic angulation to project the clavicle above the ribs, really pretty much the only thing that it's going to catch is the lateral portion of the medial portion of the clavicle, if that kind of makes sense. And we'll take a look at two images on the same patient to kind of help you get that. So what you're not really looking for is to project the entire clavicle above the ribs. You can put enough angulation to do that, but it's going to be a very steep angulation and it's going to look like garbage. So really, most of your clavicle fractures, I think I mentioned this last week, are going to be on the lateral 2/3. So a lot of them are going to be a mid-shaft. Less of them are going to be lateral of mid-shaft, but there's not going to be a whole lot that are going to be medial. Okay, so even though we still have that superimposition on the medial end, that's okay. That's okay. If you have the odd outlier that they've got a medial end fracture, then you can deal with that. You can increase your angulation if the radiologist needs you to. So notice, even though it said 10 by 12, that's clearly not 10 by 12. Your clavicle, for the most part, stands out, so you can see exactly what you need to collimate down to. You can turn your collimator housing. Y'all can't see that, can you? You can turn your collimator housing a little bit, just to make it look even a little bit better, like so. And what you should get is something like this. So your medial end is going to come with a fair amount of superimposition, and in all honesty, it looks like we've got a little bit of kyphosis going on here. So I don't know if the patient's upright and they're slouching or exactly what's going on, but we've got 1, 2, 3. It's down to 3, 4. So it's still a pretty good AP clavicle. If though, well, let's go ahead and run through this. So medial end should superimpose at least the first two. So use that to determine if the patient's a little bit kyphotic. If it's below 2, maybe 3, then the patient may be a little bit kyphotic. If they are above that, then they're probably a little bit lordotic. So rotation, you're going to look for rotation just like what you do on a chest x-ray. You're going to look at the sternoclavicular joint. So let's talk about the AP axial, and then we'll look at some images. So on the AP axial, your 15-30 degree depends on a couple of things. One is how kyphotic is the patient. So again, if you have a kyphotic patient, they're going to be kyphotic regardless of if they're upright or laying down, right? So if you have a kyphotic patient, it naturally takes the clavicles and it lowers them. So what you're going to need to do is increase your angulation. But at the same time, asthenic patients are going to require more angulation than what will hypersthenic patients. And let me reword that. People with barrel chests versus people with very narrow chests, because those are totally different things. You know, I've known people who had these big, thick chests and they never were fat, right? I mean, just big, thick chests. So what we're looking at there is what we're trying to do is get the clavicle above the ribs on the lateral portion, lateral 2/3, 3/4 of the clavicle, right? So if you got a patient, let's say our clavicles are this big. If you got a patient who doesn't have very thick chest, and I've got to have my hands not completely superimposed because the light's coming down at an angle, but the shadow's superimposed, right? So how much of a difference in rotation do I have to make in order to get the two separated from each other? I had to turn quite a bit, right? Whereas if you've got somebody who's got a real thick chest, how much of a turn do I have to make? Not much, right? So if you've got a patient with a big, turn around and go him an elbow, big thick chest, then, and they're not kyphotic, then you need to go with a much more shallow angulation. It's only going to be 15 degrees, maybe even less, in order to accomplish what you need to accomplish. But if you have somebody who's got a very thin chest, you're going to need more angulation. Thin chest with kyphosis, you're going to need quite a bit of angulation. So those are the things that are going to determine your degree of angulation. So you're almost always going to have medial rib superimposition, so we've got angulation there. And notice then we've still got 1 and 2 superimposing the ribs. Or I'm sorry, ribs 1 and 2 superimposing the medial end of the clavicle. But you've got probably 80% of the clavicle not superimposed. So in this guy, this is a good example of what the axial will do for you. So we've got a fracture here. That's probably, I don't know, what, 3/4 of the way down the length of the clavicle. And it's pretty subtle here, right? We can't really get 90 degrees. We can't get two views 90 degrees from each other on a clavicle because what we've got is other anatomy that's going to superimpose, right? So we like to get two views 90 degrees, but 90 degrees from this would be that, right? You're not going to see anything there. Alternatively, 90 degrees from this would be here, right? You're still not going to see anything. So the clavicle kind of breaks that 90 degree, two views 90 degrees from each other rule. Because of the anatomy, we just can't get that, 90 degrees. So, but we do have enough of an angulation that we can make better diagnoses between the AP and the AP axial. So we've got the fracture. It appears pretty subtle. We can't tell if the fragments are anterior or posterior. We can't tell a whole lot, right? So on the AP axial, then we could see a little bit better. So we still have that superimposition on the medial end, but we can see the fracture much better by projecting it away from, really, in this case, the scapula, right? Cool. I hate vowels, I guess.
Almost.
Yeah. All right. So any questions on those? So, it's been a week and I came back and I tried to put the images in that I didn't have in last week, and I tried not to duplicate the images that I did. That's ugly. I don't remember if we looked at that last week or not. But, no. Or week before last, I guess. So we don't have any context here.
I think it was a girl. She was in a car accident. She had like her feet in the dash.
Oh,
Yeah.
feet on the dash. That is
There's more
not
pictures
good.
of that, too.
Yeah, broken hip, dislocated hip, pushed through the acetabulum, the whole 9 yards. Yeah, that is a bad, bad position. You know, even if the dash doesn't get pushed into you, and even if you got your seatbelt on so that, you know, you don't go, you know, any further forward, you got an airbag there, and it's gonna mess you up. And I gotta put in a plug for the guys. No guy ever likes to see feet on his dashboard. Ever. Okay? So it's not just that, it'll hurt your back. Right? So don't put your feet on the dashboard. All right, so yeah. Ooh, that's ugly. All right. Heidi, what we have going on with this one? Ground level fall. Okay. So older patients, yeah, they. So it looks like an older patient, right? So fracture or just dislocation?
I didn't get to read the report.
You didn't get to see it. Okay.
But it looked broken on the portable.
Did? Yeah. Oh, y'all showed this portable.
Yeah.
That's a pretty good wide view portable. That's impressive. So so we've definitely got dislocation, and it almost looks like, you know, you can't really tell if this is fracture line or if this is a you know, skin fold or what exactly. It becomes.
Big.
It wasn't very big.
Probably didn't have, you know, just wrinkles like that. So
Right.
it did look broken on there, but I took a picture.
Yeah, and but it's definitely dislocated. Anterior dislocation, you can tell because it's in the long field. Inferior. Let's see, Morgan.
I think we just fell.
There's another ground level fall. This probably similar situation. The patient looked osteoporotic, at least this patient does. Possibly, this one looks a little younger.
Yeah, they were younger. They're two different people.
Yeah, yeah. Same thing though, just fell down. People just falling all over the place. So, you know, probably as much pathological fracture because of the the weakening of bone osteoporosis in that case. So, any questions?
How many questions
That's always a question. And my answer is, I'm not sure. Let me see if.
Where else is all this test?
Pardon?
How much wrist is all this test?
How much wrist?
That seems to be everybody's.
Oh, yeah.
Because Mindy was running through some stuff with us yesterday, and like, had a whole bunch of wrist crap on it that was like,
Yeah, it was all special projections. So it was
Oh.
all terrible.
Who did?
Mindy.
Mindy? Oh, yeah.
like we were reviewing stuff, and like there was a bunch of wrist stuff on there that was
Huh.
pretty.
I don't know. To be honest, I don't know. Let me turn this off and we'll see what I see. I don't recall a whole lot of wrist stuff, you know, in there. That may be the reason she did not review it.
You know.
Bill sees the little extra conversation.
No. All right, so for to answer your question, 65. Here's a number of questions. There's fingers, hand, finger, hand.
Is there any labeling?
Hmm?
Is there any labeling?
No.
I wish.
Just at the know, I get to question 15 before I hit anything on the wrist. And
There's a lot of elbows. That's a good question.
most complicated questions would be on
The elbow, right?
Yeah. So there are a few things on the wrist. I mean, there's 1 through 15 were all hand and finger, and then 16 through 28 look like mainly wrist, and then forearm. So it seems like it's kind of spread out pretty evenly. So,
Okay, can you?
and special projections aside from like scaphoid and
It
whatnot.
wasn't really more, it was more of an anatomy shown type of question.
Oh,
It's
okay.
like in what rotation, blah, 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 scaphoid, this
Yeah.
form, like evaluation criteria type questions.
Okay. Okay. Yeah. Well, scaphoid and the pisiform are on the opposite sides, so like lateral, just follow which way one goes versus the other. So we got.
Whenever we're talking about the elbow, can you go over the wording you're gonna use? Like, if we rotate it this way, this way, this
The
way,
what?
this way. The words you're gonna use to describe how they're positioned.
On the elbow?
Yeah.
Okay.
I understand, but I don't understand the word.
Okay. So what I would be asking is, if the radial head is projected, let's say anterior to the, or the, let's say it'll either be the radial head or it'll be the lateral condyle, right? Because that's what articulates. So the capitulum. So if it's rotated with the hand down and the elbow elevated, it's going to be anterior to, right?
So you're gonna
Anterior
use
to
anterior,
the
posterior,
trochlear.
lateral.
Mhm.
And then what would
Proximal and distal. Anterior, posterior, proximal, distal. So it'll be projected distally if the shoulder is up, right? Proximal if the shoulder is down, the elbow's elevated.
okay, that makes more sense.
Yeah.
And then on the elbow, we went over another question with Mindy, and it said that what is it?
It's just like, it asked when is the elbow
Joint space.
space is open,
Yeah.
and it said,
For the
Lateral.
AP
For the
and
lateral?
lateral.
So the joint space?
yes.
It
Was-
wasn't specific on the joint
when-
space, it just said joint space.
Okay, I bet she was maybe talking about the radial tuberosity is projected free superimposition. That would be the external rotation oblique.
Well,
You
Minnie
get
was confused about it
desuperimposition.
too, but that was just like the answer that she read from her book. So like, she didn't understand it as well as she told us to ask.
Oh, yeah. So, the joint space should be open. The joint space between the olecranon process, or the olecranon and the distal portion of the humerus on the lateral, right? You've got superimposition on the AP, so it's not going to be open. So it should be open on the lateral, but you have superimposition between the radial head and the ulna always, unless you do external oblique. External oblique separates those out. So I'm not real sure what she's referring to on that. But that would be my guess, is external oblique.
Gotcha. These aren't posted, are they? Are they supposed to?